Audio check. HSE audio check. Audio check. HSE audio check.
Good afternoon. Welcome to the Hse Press Briefing. First, could I ask the speakers to introduce themselves from the left, please?
Damien McCallion, HSE National Lead, Testing, Tracing and Vaccinations.
Anne O'Connor, Chief Operations Officer.
Paul Reid, CEO.
And Mark Brennock, National Director of Communications. And Susan and Margaret are our Irish Sign Language interpreters. This briefing is being broadcast live on the RT News channel and on the HSE Twitter feed. First, could I ask the Chief Executive, Paul Reid, to give his weekly update?
Thanks, Mark, and good afternoon, everybody. Today, January 27th, marks the day 2 years ago when we established the National Crisis Management Team in the HSE to oversee our planning and preparations and implementation for COVID-19. In that period of time, we spent a huge focus on looking at how we can protect the public and how we can protect our staff. And many big areas we've had to focus on throughout that 2-year period relate to procuring PPE, establishing a national test and tracing centre, establishing and implementing a national vaccination program, which has been quite successful, but equally protecting our healthcare services all across the country in terms of putting in dual pathways for COVID and non-COVID care. And they were very significant investments in resources and people and funding from government. And a layer on top of those 4 waves that we've had to experience, as I said before, a cyber attack on the 13th of May of last year, which impacted us for a period of about 16 weeks. So it's very truly much been a health service focused on crisis in the past 2 years. And that has had a very significant and understandable impact on our staff. Pretty tired, exhausted workforce overall, as we've mentioned before. But having said that, what has given everybody a great lift is where we currently are and the government announcements, particularly of last week, in relation to removal of restrictions across the country. And that's given our own staff quite a significant relief, not just in terms of what they are now experiencing in our hospitals, which is much better, or in all our services, which is much better. But equally, all of our staff are real people leading ordinary lives, and they too have got a great lift about where we're all at now right at this time. But it has impacted very significantly on healthcare all across the country. So right now we are currently focused on, and our priority has to be dealing with the current situation. And my colleague Anne O'Connor will bring you through some of the wider and immediate pressures on our hospital system, which we know happens traditionally in January anyway, but equally we know the incremental impact at the end of each wave and delayed care that comes forward. And that's significantly what we are dealing with right now in terms of very busy health services all across the country. But thankfully, in dealing with it, we are dealing with a good wind behind us now in terms of the, being on the right side of the slope of Omicron and COVID. As of this morning, 711 COVID positive patients in hospital and 74 in ICU. And thankfully, it's now just about 53% of those hospitalised cases with COVID were in for an initial diagnosis of COVID and admitted for initial diagnosis, and 47% now have been admitted for a different illness and subsequently diagnosed with COVID. Now, that 47%, as I said previously, they are asymptomatic primarily, but infectious. So we still have to take the same process of controls and isolation in our hospital system as we work through those numbers. But thankfully, the level of severity, as we reported here many times, is not as severe. The length of stay is continuously coming down as well. But there will be a longer tail for us out of this. So as we are experiencing a great lift in society, our hospital system in particular still has to deal with a long tail out of this process and the impacts that it has, but ultimately a really good relief for our health system overall. I just wanted today to take a few moments to just take stock of what has that whole 2 years experience been for our health system, and what are any of the kind of key learnings that we can take stock of over those 2 year period, and what can we build on, because we all know COVID is not something we all want to look back on, but equally there are many initiatives we put in place that we do see as part of the future of the health system. I just want to touch on some of them briefly. One is, I think we operated much more as a more one health system more integrated health system, and that is related to how our acute and community services work together in a much better way, but equally the role played by our GPs and primary care and pharmacies, and indeed private hospitals and voluntary hospitals overall. So much better learning for us about operating as one health system. Second key learning has been the role of our public health teams and the role that they played, previously teams who were maybe not seen above the line to a large extent, but really came to prominence and to the fore in relation to their role in a pandemic. Third learning has definitely been the agility demonstrated by our health service throughout. I passionately believe our health system demonstrated its ability to adapt quite quickly, to scale up quite quickly. Clarity on the role of the centre of the HSE and the services. I think throughout this period, we got a better understanding ourselves of what should we at the centre be focused on, what should the services be focused on, and that's something we want to build for the future to give clarity and priority. I think building the infrastructure and the testing and tracing and the vaccination programmes overall demonstrated that capacity and agility of the health system. Indeed, it's often referenced that the experience overall from Ireland, particularly in terms of our vaccination programme, being worldly recognised for our uptake. And again, we need to learn from that about what worked on communications and what worked in the process of engaging with the public. I think the role of our primary and community care teams equally came to the fore. A number of the community intervention teams, our community health networks, people experienced community care in the way that we talk about in Sláinte Care, with the right care in the right place. The GPs having access to diagnostics, over 136,000 accesses to diagnostics for GPs, which again relieved the burden on our health system. Support, we want to acknowledge obviously the support that we got from government and funding throughout that period. Many of the initiatives that we put in place would not have been able to be put in place without that funding and support. And a learning that I do want us to think about is the working with the public and our communications all across the health system in winning the trust and confidence of the public. And I know as well as anybody else how fragile this can be. But we do have very clear evidence that demonstrates increasing public trust and confidence in the health system overall. And I think that's something we want to build on, and that's something we will continuously focus on. But as I've mentioned, those learnings are important. The health system is hurt over that 2-year period. Nobody could go through all of those waves, all of those impacts and a cyber attack and not acknowledge that it has hurt the health system. But acknowledging that we do have a very significant capacity to change. So for me, I want to look forward now. Yes, we still deal with what we have to deal with related to COVID, but we do need to look forward now and see what is right for the health system for the future. What are our priorities, strategic priorities for the future of the health system? And again, I will lay a few of those just here today that we are focused on. And the first one is that we want to make sure for the future that we build and sustain a pandemic workforce capacity and capability. We did go into this 2 years ago without a pandemic workforce capacity and capability. And we need to learn from all the lessons of building that infrastructure that we put in place. And what does that look like for the future? What's the future for our testing and tracing and vaccination strategies all across? We can't devise these divorced from policy, and we will be engaging with policymakers to help us understand in terms of what's the right operational strategy in terms of giving us a scalable infrastructure and resourcing and funding to support testing and tracing, public health teams, and indeed vaccination programmes for the future. Secondly, just the very key issue for us, which is a strategic issue about investment and prioritisation of the waiting lists. Very significant waiting lists that we have all across the country, all across the various specialties that we have. If we look at the experience of what we put in place to a short-term action plan in the period of September to December, of just 2021 gone by. We wanted to put in place a range of actions to mitigate a further growth of the waiting lists. And very positively, even though that was a very tough period dealing with Delta and Omicron, we did reduce the waiting list overall by 40,000. And probably what's not seen as we talk about waiting lists is the actual activities that we carry out every year. So 3.4 million interventions or procedures across all specialties happen every year, but we want now to give a dedicated focus. We are finalising with the department and the minister, ultimately to go to government and the board of the Hse, a multi-annual plan in terms of access to care and reducing waiting lists. And we'll communicate more on that when we're at the right time. Sláinte care and regional health areas, key priority for ourselves, for government, obviously, for policy, and indeed for the Hse and our board, working through some of the major aspects of Sláinte care. Interestingly enough, Sláinte care, many aspects of it are about the regions and implementing the regions, and we will be working, myself and Robert Watt, jointly overseeing a group that will work through the design and planning and implementation of regions across the country. But there are many other aspects of Sláinte care that were policy aspects, such as equality of access and equal access to care. And I think there's many learnings we can take from the pandemic. If you look at the Vaccination Program, that was equal access for everybody. It wasn't a public or a private access. It was prioritised based on vulnerability. And that's many of what we would value from some of the policies related to Sláinte care. The primary and community teams I touched on very briefly, but we want to, in our National Service Plan, as we expect to be communicating on that very soon as well, once approved by Minister and Government, further enhancement in our community health networks, 96 community health networks committed all across the country, and further enhanced capacity and community teams overall. I think the point I made earlier on is one I think we have to stand back and value for the future, which is utilising and leveraging one single health system. Yes, we do have a private and a public health system in Ireland, but the private capacity did play a very key role with us throughout the pandemic. And I do see them as part of the solution as we go to address some of the waiting lists. And very positively, if you look at the activity we carried out between September and December of last year, we were utilising about 1,800 bed days per week from the private health system. And of that, 85% of those bed days were for people who are on the waiting lists. So that really is a support for us in the future that we will value. But when I talk about one health system, I mean how we work collaboratively with GPs and the great role that they've played, pharmacies, voluntary hospitals, statutory hospitals, community care, and indeed private hospitals. We know we have very significant challenges, no more to the fore at the moment, in both mental health and disability reform programmes that we want to commit to. And there are many activities and visions for change set out related to both. And cyber security is something that we will be putting a very significant focus on this year. We have a whole set of recommendations from the PwC report, which we've started to implement in terms of the roles to be recruited, the extra security protocols that we're putting in place to protect the network, putting together a multi-annual investment plan that we plan to bring forward to the board of the Hse and ultimately to government for an investment to protect an infrastructure which has too much components of it which are legacy networks. Obviously the priorities around patient safety and quality and enhancement of resources that will go into that, and similarly in terms of bed capacity. And we do want to continue to build on trust and confidence with the public. Just want to finally close in relation to the obviously most recent very tragic issue we're dealing with related to the South Kerry CAMHS, and I want to make a few comments related to this. Firstly, to say the obvious, it is deeply regrettable, beyond comprehension in many points actually, and just so wrong what happened in relation to the South Kerry CAMHS and the report as it is set out. The report very clearly demonstrates that some of the basic clinical oversights and prescription processes and general management processes were at least lacking, and if not in some cases abandoned. This has no doubt had a very significant impact on many children, which the report sets out, and indeed on many of their families. And none of us could bear to think how we might feel if one of those were our children who went through what some of these families and children have had to go to. So as CEO, I certainly want to sincerely apologise for what happened over a sustained period of time in this service, in this area. We do value the public's trust and confidence in our services, and there's no doubt what occurred in this incident and a period of time and in this service severely impacts that trust and confidence. I do want to reassure that the team we have in place there now, under the Executive Clinical Director and indeed the Community Officer, are highly committed and fully embracing all aspects and all elements of the recommendations as set out in the report, and are working very closely with us with the specific actions, ownership and timelines around all of the actions set out in the report. And indeed, the Executive Clinical Director was clearly communicating out yesterday in terms of related to that. At a national level, we will do all that is necessary in terms of relevant audits or checks to reassure the public and the wider CAM services across the country. Inevitably, in all of these situations all across the country today, many young children and adolescents will continue to receive good care in a CAM services, and I do want to say that all across the country, that's what happens as well. But I do appreciate that this isn't what happened in this case, and we are committed to addressing the issues that I've set out in the report. Thank you. I'm going to pass you to my colleague, Anne O'Connor now.
Hi, we're going to talk through the service update for the past week. In short summary, our services are exceptionally busy. In terms of our unscheduled care attendances, we had 25,630 people attend in the last week, and that's 6.1% up in the previous week. You can see the yellow line there on the left. It's up 41.7% on the same week last year. And again, we have to remember at this time last year, we had the surge in COVID, which saw a significant reduction in attendances, but nonetheless it was up, but even compared to the previous year, 13.9% of an increase. And we have to remember that this time 2 years ago, we were dealing with a very bad flu season. So the fact that we're nearly 14% higher than then is really quite significant for us, and our sites are certainly feeling the pressure. In terms of admissions, only up slightly on last week, up 21.1% on last year, and up 3.9% on the same week in 2019. Or in 2020, sorry, I'm mixing up my years. In terms of our over 75-year-olds, similar to last week, just down 3.3%, but that's a 31.9% increase on last year and a 9.3% increase on 2 years ago when we had the flu season. And again, that flu season saw particularly high numbers of attendances from older people. So that is a significant increase on 2 years ago as well. Admissions down 1% on last week, that's up 22.6% on last year, and up 5.7% on 2 years ago. So a very high level of activity across the country in many of our sites, and we are seeing some sites that are really under quite significant pressure in the past week. Our patient experience time, similar to last week, 0.2%, and not much variance there. Last year or the year before, and our 9-hour patient experience time for over 75s down 2.6%, which is down 14.1% on last year and down 4.5% on 2 years ago. In terms of trolleys, we have seen, I suppose, a continual increase now in trolleys in the last number of days. There you can see the yellow line climbing up, and that's up 6.6% on the same week last year. Up very significantly, so 161.7% on the same week, last year because of the reduction. So again, this time last year, very low numbers attending, really no trolleys because we had created capacity, so had much improved patient flow, and that is down 13.6% on 2019 when we had the flu season. So we might ask, what's different in terms of, why is the congestion there in terms of just people not being able to move through our hospital system as quickly? And we can see there in terms of our capacity that on the left you have the trolley count in terms of that yellow line being the past 7 days compared to 2021 in the red, so last year, and the green the year before with the flu season. So we've now kind of passed over the green line there in terms of being busier for the same week. But critically, on the right-hand side, you see the graph, and we don't usually show this one, which is the surge. And this is really what makes the difference. And it's the difference that we hear reported between the HSE trolley count often and the INMO trolley count in terms of what's counted. So our surge capacity is when we use extra beds to admit people to places that wouldn't be normal hospital wards, if you like. So we use our acute medical assessment units, we use our surgical day units, and what that does is, in effect, take away that capacity for other things. So you can see that that number went right up to 456 on the 24th. It came back down to 367, and now back up to 396 today. So it's, you know, a significant number of our beds that are being used in places that wouldn't be wards, if you like. So the combination there of the trolleys at 356 and the surge beds at 339 give you the real reflection of the pressures in unscheduled care.
2020.
The yellow is 339.
It went down, went up.
Oh, sorry, you're right. So continue to climb. So in terms of the surge use, so we've seen that it's been consistently busy. And that is what adds the pressure. So in a hospital setting where you have high numbers of people coming into unscheduled care and you have a high use of surge beds, and it's something we capture every day, that adds to the pressure in the site, and it certainly gives to, I suppose, increases the congestion within acute hospitals. In terms of our delayed transfers of care, this is something that has increased as well. So that number of 571 on the left there, they are the people who could be somewhere else, either at home or in a nursing home or in another facility receiving some kind of specialist care. So, for example, awaiting rehab or some other type of step down. That number has grown considerably. As you can see, the yellow line there has gone up. That is related in the main to the outbreak situation in nursing homes. So even though we are seeing improved situations in respect of COVID, within our residential care and our older person services, we still have significant challenges in terms of outbreaks, and that is impacting very significantly now on many of our hospitals in terms of being able to discharge people to nursing homes. We're seeing that particularly impacting on the West, the Midwest and the South-Southwest. And today we see issues in South Tip as well. But our delayed transfers of care are a particular focus for us to get that number back down because they are in effect beds that could be used for people coming in through the front door of the hospital instead of waiting to go out the back door. So very important measure for us. And you can see there the top line, so the darker line are the people coming onto that list. And we like to try and match, so it's important that we keep the number of people coming off our delayed transfer list. Obviously, kind of that's more active than the people coming on, but you can see there that that just hasn't been the case since the beginning of January, since the end of December, really. And that is wholly related to the outbreaks and also the challenges in respect of home support. So they'd be the two big areas in terms of the reasons behind delayed discharges. When we look around the country this morning, we can see a number of sites that are under pressure. Just to draw your attention to the West Coast, as I said, very significant challenges there. Mayo, 23 people there this morning on trolleys. Very high number of presentations for Mayo in terms of 120 people were in their ED on Tuesday. Galway, 48 people on trolleys this morning, which is a very high number. They also have surge in use, but important to note there, they have still got 3 wards that are in effect taken over by COVID. So they are the hospital with the highest number of patients who are COVID positive in the hospital, and that is impacting significantly on their bed capacity and their ability to move people through. They are also significantly hampered on the other end in terms of discharging people due to outbreaks in the nursing home sector. Very high numbers of presentations, so 249 there on Tuesday. Cork, 25 this morning. You can see all of these sites, very big numbers. Limerick, 255 presentations, significantly higher than previous years, and they had 21 people on trolleys. They had, however, also got a high number of surge beds in use, and they have also opened additional capacity or moved people to Croom in terms of actually accessing that capacity for unscheduled care and for medical patients, which does, again, have an impact on their ability to do other planned procedures. And I'm going to talk more about Limerick in a minute. In terms of our ambulance activity, that actually overall is back within a normal range, so nothing extraordinary nationally. But when we go on then to look specifically at Limerick, and I've chosen Limerick and a couple of other sites because we hear a lot in terms of the pressures in Limerick, and we hear a lot about some of our big sites being under particular pressure, and just to understand that a bit more. In Limerick, you can see that yellow line has gone way up, so 1,592 in terms of attendances. And that is really extraordinarily high. So much higher for this time of year compared to the previous 3 years. And we can see their admissions also going up. So again, that yellow line sitting above any of the previous 3 years. So 505, very high numbers of people being admitted into Limerick. Their ambulance chart shows, again, an extraordinarily high level of activity. So these are people who are being relayed and transferred to hospital by ambulance. And you can see that it sits really off the scale in terms of the level of activity going on in the Midwest. When we look at their activity, we can see there that they're actually significantly higher. So again, these charts just show you their attendances and admissions, both for the general population on the top and over 75s on the bottom. And we can see there that their attendances for Limerick in general, 42.7% higher than last year and nearly 32% higher than 2020. Now that's against a national average of 21% for 2021 and only 13% for 2020. So their attendances, their admissions are significantly higher than the national average. Interesting to note, their admissions are up 25.6% on last year, but 15.3% on 2020. And again, the national average for that was 3.9%. So the level of activity that they're seeing is really very notable, and that's why I was keen to put it up today. Equally, their attendance for over 75s is 21.3% higher than 21 and 15% in 2020. So we're just seeing a common theme here of the level of activity in Limerick. And when we look at two other key sites that are also under significant pressure, we look at Tala and we look at St. James's. So Tala have significantly high attendances. They feature on our trolley guard. They feature in terms of use of surge beds. And their attendances are up 26.5% on last year. But when you look at their admissions, it's only up 3.6%. And likewise for 2020, their admissions are actually down on 2020 by 3.7%. So similar, big Model 4 hospital, very high levels of activity, but not the same level of admissions. And what we can see in Limerick is that the level, so I suppose the rate of admission and the conversion rate is very high. They are seeing a lot of very sick people coming through who need hospital beds. Likewise in St. James's, very high levels of activity, up 35.5% on 21 and nearly 12% on 2020. But in terms of their admissions, they're down on 2021. And only 5.5% up on 2020. So this is just, and it's a busy slide, so apologies about that with all the numbers, but it's really just to show the extraordinary level of activity that is going on in some sites and the challenges that that presents in terms of using up ED space, surge beds, and then the reduction in ability to do other things in the context of us still having about 4,500 staff out on absence across the country. In terms of our outbreaks, we have 720 open outbreaks in hospitals and long-term residential care, 3 new outbreaks in hospitals and 10 in residential care facilities. And important to note that 48% of all older persons units are now experiencing outbreaks. So that number is still a very high number. And as I said, having a very real and material impact on our ability to have people moving through our acute hospital system. Just in terms of our nursing home serial testing, that continues. So the 20th cycle there showing a positivity rate of 5.05%, which is higher, but we're not seeing the same level of illness coming through. In terms of the average number of cases per outbreak, it's at 7.79%, and we've had 92 new confirmed outbreaks across all community facilities in the last 7 days. Paul touched on this, I think, so 711 people in hospital today with COVID, and we can see that graph is coming down, so the numbers are improving, but as I said, if you take an example of Galway, still quite a high number, 3 hospital wards currently being used for COVID. Just wanted to put this up, and Paul made reference to the great success that is the GP Access to Diagnostics initiative. The reason I've put it up is because we've had the highest week ever in the past week. So we can see there that 4,913 tests have been carried out in the past week. That continues to be a very successful initiative. We have a lot of work going on now looking at how we can actually match that with waiting lists, for example, in terms of our hospital diagnostics. Not an easy thing to do, but we are looking to see really where this is having an impact, because the level of activity is really very high, particularly in relation to MRIs, which continues to be the highest number of tests. So I'm going to leave it there and hand over to Damien. Thank you.
Okay, good afternoon. Thanks, Anne. I'm just going to briefly go through just where we're at in terms of testing and some of the trends. So what we are seeing in terms of the GP referrals and community referrals is a substantial decrease, over 40% across those two pathways. Having said that, that's from a very high bar, which we've had in recent weeks. Positivity has also dropped from 55 to 48% in terms of the community. But again, that pace of that drop, I suppose, has decreased somewhat in recent weeks also. Our laboratories are still busy, but nowhere near the peak where they were doing over 300,000 and we're down at 121,000. And again, I suppose that's all relative. If you move it back into maybe the quieter periods in the summer, those numbers are still quite strong in terms of what's there. Anne also mentioned the outbreaks, again, the impact they're having on the system, and that's still having to be managed through the healthcare system at the moment. Then on our antigen testing side, and as we know, there's a number of pathways here in relation to the antigen tests. We still see a good demand, and those form into two groups. One is in relation to where the public health advice recommends antigen tests. Those are for the symptomatics under 40, for close contacts. And then we have screening programs or other programs in relation to primary school pods, early years, healthcare facilities and other such initiatives. So again, the overall usage last week on that increased slightly, but that did include a substantial number on the screening side. So again, in terms of our headlines, still busy, but nowhere near the levels we were at in the peak. And as I mentioned, the trajectory is clearly downwards, which is a positive thing. Again, around referrals and swabs and lab tests, I've mentioned those numbers. Our contact tracing is still busy, but again, the number of close contacts has increased slightly to 2.6 from 2.5, so nothing major. And our overall performance, I suppose, in terms of end-to-end result for people has improved substantially in recent weeks, down there to a day for not detected and 1.2 days for detected results. Positivity, I've mentioned earlier, still quite high at 48%, but again, decreasing week on week. So overall, I suppose we are continuing to see a continuous rapid downward trend in demand and positivity week on week. Again, I've mentioned the community referrals, GP referrals, and then consequently the laboratory results, all decreasing as a result of that. Slight increase in the antigen test, but again, partially accounted for by some of our screening programs. Those through the public health advice are continuing to decline in line with the PCR testing. Close contacts, again, marginal increase. And as Anne mentioned, we're continuing with our serial testing program in nursing homes for another couple of weeks. We're also continuing to plan for further adaptation in terms of any further public health measures that may come in when these measures conclude towards the end of February. So we're working closely with colleagues in the Department of Public Health to look at how we do that while ensuring a level of resilience in our service going forward. Just moving then to our vaccination program. So 2.6 million boosters or additional doses have been administered. In our children's services, we've seen 120,000 people registered and 93,000 vaccinated. We are seeing a slight slowdown in this, but the second doses have already commenced, and I'll come on to some of the initiatives we're doing there to try and encourage uptake. So overall, again, we're still doing very strong between second and third in the EU on a daily basis, like a football league table as we swap up and down. But in overall terms, we're continuing to perform very well across Europe, but we have seen a reduction in recent weeks. So again, there's a piece just in terms of where Ireland is at in terms of the current position as of the 27th of January. So what I just want to reinforce there for people in terms of the general public is the primary vaccination process, we're still offering that, and we're still seeing small numbers, around 8,000 through for dose 1 and dose 2 in the last week. And again, we'd encourage those people to come forward, because as we saw from the data that's presented here every week, many of those people who were unvaccinated from a primary vaccination perspective are the people who end up in hospital. So thankfully, we're still seeing small numbers trickle through, and that opportunity is there for people across our centres. For people on the booster programme, again, the range of options available to people in terms of the vaccination centres themselves, participating pharmacies, and GPs then for those that are participating also. GPs, at this stage, some of the GPs have completed now the accelerated programme, which was a real success. Over 1 million people in that 4-week cycle where we really put in a very condensed focus on the booster programme were vaccinated, and we're very happy with that outcome. But as I say, we see significant challenges at the moment in relation to just trying to complete, I suppose, and move forward in relation to the booster programme, particularly in the younger ages. So the initiatives that we've undertaken is working with GPs with third-level colleges. We're refreshing a lot of our communications material, running additional campaigns through social media. We've commenced the programme for those people who were immunocompromised in the first round, over 100,000. They will now get their dose, their booster dose You may recall that initially they had their third dose, but that was part of their primary dose. So they're now commencing in relation to their booster. And we would encourage those people particularly to come forward because of the nature of the conditions that they have. And they're being contacted with a view to appointments as we speak. So a range of initiatives have been undertaken, and also, of course, in terms of the travel certificate, while that's not a health care initiative, that from the 1st of February will cease to be effective if you're over your 9 months. So it's going to be important for people to remember that as well. And again, that's just another factor that people may need to consider. But from our perspective, we would encourage people to come forward for their own benefit in terms of their own health, those people they live with, their family and friends. And as I say, there's a range of channels available for people to access that. Thank you.
Thanks, Damien. And we take some questions. If you give your name and media organisation. Yes, Fergal.
Fergal Bowers, RTE News. Can I ask Paul Reid, just in relation to the Kerry Cams issue, which he referred to there, what reassurance can you give the public that they shouldn't be concerned that what happened there could happen elsewhere nationally in the service? Because we often hear GPs saying there's quite difficulty sometimes getting access to CAM services for patients, and sometimes they have to refer them to emergency departments.
Just to restate again, what happened in relation to Kerry and CAMS was at least regrettable, but so wrong what happened. Just in terms of assurance, there's no doubt all across the country today, many young children are attending mental health services, whether it's in the primary, in our primary community services, or indeed through NGOs, and getting good care, and indeed in many aspects of our CAM services across the country, getting good care too. So I just want to acknowledge that what happened in Kerry was absolutely wrong. In terms of assurance, we will be working on a national basis now to complete audits in terms of compliance with standard operation procedures set out for CAMS teams and how they would work through those processes. And equally, along with that, looking at prescription levels comparatively across the country to give assurance to us on a national basis. So we will embrace every element of this report and equally look nationally into what has to be strengthened.
The Irish Hospital Consultants Association puts the figure of the number of consultant psychiatry posts unfilled or filled on a locum or agency basis at about 1 in 3. That was pre the pandemic, so around this time last year. Is that a problem that you might have vacant posts, or also anyway posts filled on a temporary locum basis? It's not ideal in a service of this special nature where you want the consultant to know the patient, maybe know the family over a long period of time for continuity of care.
Yeah, let Anne give some specifics, just to make a couple of points. First of all, in terms of recruitment of consultants, we are funded for it, and we're working nationally, internationally, globally to recruit consultants. Last year, in the period, January 2020 to December 2021, we recruited over 360 consultants. That's a net increase in consultants overall across the board. There's no doubt in terms of mental health and consultant psychiatrists in particular, it's a real challenge. We have about 80 79-point-odd whole-time equivalents in position, and about a further 6 working on development positions. But it is a challenge in terms of recruitment, and that's one of the issues we want to be focused on, but it's not easy in the market at the moment. And do you want to?
Yeah, so maybe just to say, we have 73 community teams around the country. I think we have about 76 consultants, and as you say, Fergal, some of those are locums, and that is the reality of our health service, unfortunately, not just in CAMS or indeed just mental health. One of the things that we've been undertaking now over many years, an improvement initiative around CAMS, and in particular the training. So the reality is that, you know, when we look for CAMS consultants, we are competing in a global market, and every country is challenged. So there is no country that I know of that doesn't have a problem actually getting CAMS consultants. What we have done is worked very closely with our training bodies. We have increased the number of higher specialist trainees. So we had 22 trainees. So if you look last year, we have 22 coming out of our higher scheme, so people who in effect would be qualified to work as consultants. Within that number, there were only about 3 or 4, a max of 5 that ever were CAMS trained. So our problem as a system is because it's not that big, even training people is a challenge sometimes. We've now worked very closely, and this year we will have 46 higher specialist trainees coming out, and within that we'll have 13 who are CAMS trained. So that's a very significant increase in the number of people. Now, we can't say that those 13 people are going to work in CAMHS in Ireland. That's the big problem, and it's up to us to try and attract them to do that. But certainly in terms of the work that we've done with the colleges, in recognition of the fact that there is no cavalry coming over the hill here, we've put a big focus on increasing the funding for training. And as I say, we hope to have 13 CAMHS qualified people coming out this summer.
And just in relation to the audit that's going to get underway, nationally, Paul Reid, can you put a sort of a timescale on how long that may take?
I think we're just defining the scope of it right now, and we're working with the Minister, obviously, in relation to that. We want it to be thorough. So I can't give you a definite time by now because we want to get the scope right. We want it to be accurate. We don't want to, go too deep where we don't want to go too deep. We want to go across the board in all of, as Anne said, the 73 CAMHS teams. So we'll be defining the scope and communicating it out shortly.
And there isn't a national standard guidance, so we have to come up with the criteria against which we're going to do that.
Priscilla Lynch, Medical Independent. Damien, just a question for you, please. Is there any plans to reinstate PCR testing for age 40 to 39-year-olds in the first instance, seeing as demand has significantly dropped and there seems to be a lot of anecdotal reports that schools are really being flooded with cases in the last couple of weeks? And secondly, do you have any data on the amount of vaccines that have gone to waste in the last couple of weeks, as in that they've expired and in the next week or two? I know that's something that's inevitable if you don't have the numbers coming forward to get their booster shot.
Sure. On the first one, I suppose that public health advice is determined by NPHET, and that's in place now till the end of February, so it's unlikely to change in the short term in relation to that current advice. But we're working with the department and with our own public health teams to look at what the shape of the next advice might look like based on, the trend of the disease. In terms of schools, we continue to offer in schools in early years that close contacts, the pod testing. And we are seeing continued use of that also in relation to the schools themselves. So that's part, I suppose, of the overall response around schools, which public health would work with education on. In terms of the vaccines, I suppose to date, we've certainly seen, I think, as we've said, well over 200,000 expire in that recent period, and we'll continue to monitor that. But it is going to remain a challenge as we've seen the numbers shrink. We are still ensuring, I suppose, that we have access to vaccine across general practice, across pharmacies and across our vaccination centres. And, there's 1,300 practices have been participating, over 700 pharmacies, and we have our 35 vaccination centres. So we're managing that stock as tightly as we can, but clearly we also have to try and make sure that it's available to people. And we would encourage people to come forward, while obviously that's a consequence perhaps of uptake, but we would encourage people to try and utilise it now, because our research is actually showing from recent research that close to 70%, 68% of those people who aren't boosted have indicated they will do so. They just haven't got round to that yet. And we're keeping to run that research, I suppose, just as we go through the weeks. So we would encourage people to come forward early, because for their own benefit, but also in terms of minimising the impact. Now, we do know there's significant numbers that are going to have to be done over the next 3 months who were COVID positive over Christmas and who have to wait the 3 months. So we'll also be continuing to offer the service through the next 3 months, and we're working that through at the moment. So it is going to be a sort of a funny phase now for the next 3 months, where there'll be smaller numbers across all the various vaccination programmes, from the paediatric side to the adult side over that period.
Ask a follow-on question. Just for if you've had COVID, you have to wait 3 months till you can get another vaccine. In the UK and other places, it's a month. Is it the same for children? And is there any plans to change that advice? And then for the testing of the pod system in schools, that's just antigen testing, isn't it? It's not PCR testing.
Correct, yes. So the schools one is antigen testing in terms of the pods. In relation to any changes in advice, that will come from NIAC. They have looked at this before, and different countries have different periods in terms of 1 month, 3 months, some are even further in terms of 6 months. So at the moment in Ireland, it's at that 3 month window, and unless NIAC change that advice, and they have looked at this extensively in terms of the research around it. So that's what we're working to and planning for at the moment.
Just going back to the South Kerry CAMHS issue for a minute, is it known at this point, like, what kind of caused the issue in terms of kind of these problems around prescription? Was it a case that the junior doctor in question didn't have enough help? Was there like some kind of staffing issue? So is that known?
I think the report is the report's very clear. It sets out with 5 different criteria about what the issues were, which contributed to the overall failings, the CAMHS issue. And some of it was clinical oversight, some of it was over prescription, some of it was related to the management and organisation, Some of it was issued to a lack of awareness around risk and risk management. So there's a whole suite of areas in the report that are very clear, which contribute overall. And certainly one of those was the overprescription by the junior doctor themselves. So it was a range of factors, which overall the report sets very clear recommendations on. Andrew?
Yeah, and important to note as well that the report doesn't really talk about staffing deficits in the sense that it's not a resource issue. So this hasn't arisen because there isn't enough money being invested in CAMHS or any of that. This was how the team worked and the practice of the team. Not about the fact that the people weren't there as such. Obviously, the fact that there wasn't a consultant in that team was a fundamental problem. But overall, it was about practice, poor practice.
And oversight, clinical oversight and clinical governance.
Sorry, is that not a bit of a contradiction? Like, you're saying there wasn't a staffing issue, but you're also saying that the fact that a consultant wasn't there was an issue. So, like, do those two not really contradict each other?
What I mean is overall in CAMHS, so there was a team there, and the fact, yes, as I said, a consultant, the fact that there wasn't a consultant there and that team was being supervised by another team, if you like, or a consultant in another location, was the fundamental issue in terms of the supervision and the oversight. But my point is overall in CAMHS, there is investment, there are teams, so that isn't the fundamental issue here in terms of the need to have a lot more people. Obviously, we'd love to have lots more people, but the important point is it was about how people were working. So it was about, as I said, it was about practice. It was about oversight of people who were there.
Just because I think, as was alluded to earlier, like, it has been raised by the Consultants Association and others about the difficulty in recruiting consultants. And I know you're saying that it was just kind of how they worked, but it seems like there was a problem here where there wasn't a consultant given oversight, as you said yourself. So, I mean, specifically around the recruitment and retention of consultants, I think work practices has been kind of cited as the biggest issue, and poor working hours and long working hours. So is there anything kind of practically being done there to improve working conditions for doctors and for consultants to improve retention?
But as I said, we've recruited, so in terms of the higher training, we have increased the numbers of trainees, and that's a very significant investment in terms of increasing the number, and this is in psychiatry, the number increasing from 22 to 46 this year, and increasing from 3 to 4 CAMHS trained consultants to 13. So that is, I mean, in terms of the overall number, so we have 73 teams, so if we have 13 people coming out who are CAMHS trained every year, and it'll be the same next year and the year after, that's a very significant increase in the number of people who are available to be employed as consultants.
Just specifically, I mean, because I think your question is broader, it's not just related to CAMHS, but the wide range of supports for consultants. I mean, we know it's not just about the pay, attracting consultants. Just make the point again, we have increased consultant position posts by 360 in the last 18 months, 2 years or so. And that's a net increase. But issues around working environment, supports for consultants have been set out in many reports previously. We have significant recruitment ongoing to support consultants and multidisciplinary teams, because we know there are other factors, not just pay, at play. And I do acknowledge them.
Sorry, just a final point on that, to follow up on what you're saying, Paul. I mean, is there kind of anything a bit more concrete being done to improve those conditions then? Because like that, we're talking about the number of people in training, but surely if the working conditions stay the same, it's not going to make too much of a difference if you still got that retention and recruitment issue.
I think you have to look at this at a global level. As Anna said, this is a big global demand and market, never more competitive than it is now in a pandemic and just after a pandemic for us, where we are now. And that's the reality of the market of attracting consultants. There's no doubt within the workforce we want to make the environment better. Some of that is around the multidisciplinary team supports. Some of it has been the issues and actions taken around the European Working Time Directive and working hours for junior doctors in particular, and a range of initiatives taken across the Hse. Some of it is clerical support, supporting outpatients clinics. So there's a range of initiatives that we know we need to invest in further, but we have invested in as well, particularly over the past couple of years.
And also a lot of work has gone on in terms of developing the multidisciplinary team working in CAMHS. So when we look around the country, there are teams that work really in a multidisciplinary way. So one of the findings in relation to this team was the extraordinary workload assigned to the doctor. compared to other team members. So in terms of how a team works, that's also, I suppose, an improvement thing for us in terms of looking at how the team, so we see other teams around the country where it's much more even, and we have many different types of specialist staff working in CAMHS, not just doctors. So for us, it's really about working in the way that is set out in terms of our operational guidance. We have different initiatives there in terms of enhancing teamwork, for example, in mental health, which really looks at how our mental health teams work and how they can work better. So all of those improvement initiatives will be put in train down here too.
And sorry, Paul, one last thing. There are about 37 clinical pathways that we are looking at and investing in as part of our service plan to address waiting lists. And that is about supporting that. It's not, as Anne just said, that it's the expectation or requirement is on the consultant. There are multidisciplinary teams who can address some of the waiting lists with us in a different way. And consultants are leading that clinical pathways revision with us across 37 different pathways at the moment.
But hopefully this will be the final question just on the subject. I think there's kind of been a bit of a sense from a couple of people saying that, there might be kind of like this kind of particular junior doctor might be kind of held up and kind of blamed, I guess, for a lot of the issues. But I mean, as you guys have kind of said yourself, it seems like there was like an extraordinary workload in this one particular doctor. And I know what you're saying, Anne, around there not being an issue in CAMHS generally in terms of staffing, but it seems like there was a staffing issue here. So is it not the case that like this seems to have been come about in large part not because of issues with this one particular doctor, but because of staffing and structural issues in South Kerry?
So I think just to be clear, in terms of what I said about the issues around staffing in CAMHS, I think the report didn't point to resources being the key issue. But definitely in terms of this team, the challenge is in terms of how a doctor worked in the context of being a team member, and the fact that from a clinical oversight perspective, there wasn't a consultant with that team in terms of, so any non-consultant hospital doctor should be working under supervision, regardless whether it's in mental health or any other specialty. In this case, clearly that arrangement didn't work, and the practice was substandard, and that is what we are dealing with. However, equally we know that in many, many teams, there's an extraordinary high level of supervision and team working that goes on. And as Paul said in CAMHS, and just to give reassurance, we have some world-class CAMHS services in Ireland, and this incident is, it just should not have happened. So,
just clear, Paul, the report doesn't scapegoat the junior doctor involved at all. In fact, the report states it would appear there was no intention to harm. And the report then goes on, more so as Anne had said, it touches things like governance, oversight, supervision, risk management, team working across shared roles. So it has a whole range of initiatives and not to scapegoat one person in it at all.
Just on the vaccines, Damien, if any of those are likely to expire, is there any plans to donate them to other countries?
Yeah, there's two different levels, I suppose. So there's those vaccines that we hold in our central freezers, and those that we've government redistributed. I think nearly 1 million vaccines last year to the COVAX system, which is an international system to support developing countries. And then we also did a bilateral agreement with Uganda, you might recall, last year for over 300,000 vaccines. So in terms of what we have in our freezers there, a process I suppose we work through regularly with the Department of Health to identify opportunities in terms of just looking at the stock relative to the uptake. The challenge at the moment is once the vaccine is out in what we call the vaccination channels, the GPs, the pharmacies, it only has 30 days. So there is no possibility of repatriating vaccine once it's distributed. So that isn't an option in terms of that level. But for the central freezer system that we have, yes, we've looked at bilaterals. We did that before, and we may well do that again. And separately then, in terms of from the manufacturer, we also look at redistribution there, but that's a policy decision for government. But we would obviously work closely with the department on that.
Paul Cullen from the Irish Times. Again, on South Kerry, Paul, HSE has sent information to the Medical Council. They're empowered to follow up on professional matters with doctors. But where is going to be any accountability for the managers who are involved and who are mentioned in the report as well?
Yeah, look, we're going to look at all aspects of it, and we will be liaising very closely, Paul, with the local team involved, and they will be looking at all aspects of any further follow-up, whether it's accountability, responsibility. The report, in fairness, addresses issues that do legitimately need to be sent to the Medical Council, and obviously, as you've been reporting on yourself this morning, to the Gardaí for review. But in terms of the wider sets of issues that come through it, it does show a whole set of organisational failures around the organisation of the resourcing, the appetite for risk, or the awareness around risk management, the awareness around records. So a whole suite of initiatives, not necessarily in themselves, Paul, disciplinary issues, but things we have to address. But we will be working with the local teams to assess that further.
And you mentioned you're drawing up a waiting list plan. The last I heard of the waiting list plans, they were being drawn up by people involved in the Sláinte care process who have since departed, and that never came to be. So is this a new approach? Is this superseding the work that was done? It was loads of work done on this last year. It was all but ready to be published before people left. And I suppose, when are we going to have this plan? Because just Anne, I think you said, or one of you said, that numbers dropped 40,000 or something, but that was in the latter part of the year. Both the main waiting lists were higher at the end of the year than they were at the start. So they actually increased last year.
Yeah, just to take the answer, Paul, in three parts. The first part, we certainly won't be throwing the baby out of the bathwater, and work that was done previously will be a core component of what we'll build into the plan as it's published and finalised. I don't think there's many kind of unknowns about what the elements of the plan will be. It will be utilising the most effective use of the €200 million Access to Care Fund in the budget allocations for this year. And in doing that, looking at what can we get done further on top of our base case for our service plan within the public system. What can we utilise the private system for? What can we engage the NTPF specifically for? Some of those new clinical pathways I spoke about will all be part of it. The finalisation of that plan is a dual process, engagement process between myself and many members of my own executive team, and directly with Robert Watt, Secretary General, and some of his team to bring it to finalise. When will it be finalised? We're working through. We're anxious to get it out as soon as possible, but we'll be working with the Minister. I would say realistically in the coming weeks, but it can't be more specific than that. Just on your factor about yes, waiting list roles, we know, and I think Anne has shown it here. After every wave, as we come out of a wave, we made progress on waiting lists, and as we go back into a wave, we go backwards again. In the period of September to December, though, I do want to reference what we did put was a very short-term action plan that was published, and it had a range of those actions that I just set out there, and oversight that I put on here, and both Robert and myself put in on a joint level meeting weekly and fortnightly. And many of the actions in that will be part of our multi-annual plan, but it did have an effect to at least mitigate the impacts during a difficult period for Delta.
And the cyber attack, which had a huge impact on waiting lists.
From the Examiner, can I just start with the CAMS issue again? The CAMS services have sort of traditionally been seen as the Cinderella of the Cinderella in the mental health services. Is there any thought given that this situation could be used now as a root and branch review of how CAMS work? There's been a lot of concerns about how isolated a lot of those 73 teams are. They're not closely integrated with the hospital system or with each other in many cases.
Yeah, so I think CAMS, there's been a lot of work going on in CAMS, and I don't want in any way to take away from the incident that we're talking about, but just in a general sense, in CAMS over a number of years, we've seen significant change and reform, and certainly a number of years ago, we were dealing with quite a different situation in terms of CAMS being very much disconnected from mental health services in an area. And, for example, having high numbers of children being admitted to adult units, etc., children waiting over 12 months, children going to the UK, all of those things. What we've been working on now for a number of years is really the kind of integration of CAMS within an area's mental health service under the Executive Clinical Director, so in terms of clinical governance, because that wasn't always the case. CAMS kind of originated from a child welfare model. So they come in under the ECD, it's a clinical service. And we have to remember that CAMS is a very specialist mental health service. Only 2% of the population will need CAMS and only 1% will need admission. So it's not a service for everybody. And the reality is, and something that we identified a number of years ago, is that many of the challenges arising in CAMS arose out of a lack of other things being available. So we've put a lot of work into working with partner agencies, the likes of Jigsaw, spun out so we've kind of invested a lot in other responses to youth mental health. And this also came out of the Youth Mental Health Task Force. The reality is, if we're only talking about CAMS, we've lost the plot, really, in the sense that there are many young people who need supports that aren't in CAMS. They need them in their schools, they need them in primary care services. We have the development of the Children's Disability Networks now, which give a pathway there. So we've done a lot of other things. And I think for us, in terms of CAMS, we have done a lot of work also on the operational guidance in terms of trying to standardise that model. But what I would say is that we've seen, so for example, if you take the admission of children to adult units, that's, 3 years ago, that was about 83 children. Last year, down to 25 children. And they were kind of older, so they were the kind of 17, nearly 18-year-old bracket. We've seen a significant improvement in children waiting long periods to be seen, and so on. So that there's a whole range of improvement work, Niamh, that has been undertaken in CAMS over many years, but it is slow, and we have 4 inpatient units nationally, so 72 beds with 2 high dependency beds in Dublin, and in reality we have about 55 children in those beds. So again, the pressure, we have a whole system now with the paediatric hospitals in terms of ensuring that we have a pathway for children to go from paediatric hospitals in, etc. So a lot of that work has already been underway for a number of years. That will continue, and obviously we will use this incident to learn and to improve more. We will continue that improvement work.
Okay, thank you. And Anne, again, just on the carers, you mentioned the pressures on home care. Do you have any number now for the number of people waiting for home care packages?
No, I could make it up and tell you it's about 8,000. I don't have it on me, Niamh. I'll have to come back to you. Unfortunately, it is not an improving position. So we have seen an increase in the number of people awaiting carers, again impacted by COVID. The number awaiting funding was at about 400 and something, predominantly in CHOs 7 and 9, which would be 2 areas where actually they have had quite good success in terms of getting carers. But we know that there are other parts of the country where there are very significant challenges. So I'll have to come back to you with the specific, the actual number, but it hasn't improved, unfortunately.
Thank you. And just, Damien, on the vaccines, do you have a breakdown in the children, the 5 to 11 years, how many of those high-risk children have had their vaccines now? I think it was 10,000 overall, was it registered?
Yes, so all of those that would register would either have been vaccinated or given appointments. I couldn't tell you the split. Some people could obviously seek to reschedule those, Niamh, but all of those would have had their appointments or been vaccinated. The vast majority would be vaccinated at this stage. It's a self-declaration process, you might recall, so they just registered early. So again, if there's a young child that's still in that category, they can still register and they'll just be picked up as normal. And we're generally getting those appointments out now within 72 hours, so it's a fairly rapid process.
Paul Quinn, Virgin Media News. Paul, can I just ask you in relation to COVID? Obviously, last week we saw an easing of restrictions in hospitality and social distancing. What's the situation in hospitals with regards visiting and visiting patients? Has there been a relaxation there, or what's the current state of play? And going forward in the next couple of weeks, I think there's an acknowledgement that cases may go up. Obviously, the vaccine rollout will have an impact. But what are your concerns about what we might see in the weeks ahead?
Yeah, overall, look, I think it's, as I said earlier on, it's giving our hospital system a good relief because numbers of patients coming down. But it is a longer tail for us. We still have over 700 people in hospital. They still have to take all the precautions, infection prevention controls, and they still have to protect further transmission levels within the health system because it still transmits very quickly. And we are dealing with vulnerable people and patients. Generally, across the board, visitation is working well. There may be some specific sites where they have high numbers and high risk, where they may, and that happens on many occasions through COVID, where they still have to put some level of restrictions in place. But generally, across the board, it's visitations are progressing well, and that's a relief for our own teams as well, working there. I think your last question is what happens next, I think this has given our healthcare teams a great relief too. We all hope that we're on the right side and continue to stay on the right side of the impacts of COVID. The only thing we can always say is we don't know. And many times throughout the past 2 years, when we thought we were there, something else came along. So, we'd be relying on the science and the evidence. It's happening worldwide, but we do hope it certainly feels a lot better for our teams at the moment.
Anne, can I just ask you about the pressure on hospitals? Obviously, this is the time of the year, even without COVID, where hospitals would be under pressure. But Limerick in particular, and you're saying this, unprecedented pressure on their system there. Why is that? What's going on in Limerick that they're seeing such high admissions into hospital?
I think there's a number of things impacting, and like Limerick, it gets a lot of attention. We know that. There is one emergency department in the group. So in other groups, there's more. So they have one emergency department and they have one Model 4 hospital. And the reality is all roads lead into the Model 4 hospital. That's really part of our problem here. So we have 100 extra beds that went into Limerick in October of 2020. And they made an impact, but in reality, they just stepped in time for COVID. So they became the COVID isolation beds. And what we see in Limerick is an extraordinary high level of attendance. So we have Nina and Ennis and St. John's working as part of the group, and we opened new capacity in Croom Hospital. So the decision that's had to be made there is that we actually use Croom now for some medical beds. But if you look at an area in terms of integrated working, for example, in the Midwest, they do fantastic integrated working with community services. They're doing huge work on enhanced community care. So they're doing all of those things. And yet the demand is so high. So the reality is, and for us a real measure is the conversion rate. So if those people who are attending are admitted to hospital, they need that level of care. And that is really it. But they are also impacted at the back door because in the Midwest, they've had a very high level of outbreak as well in their nursing homes. So it comes back to patient flow. If we can't move people through, if we can't move them out, the hospital gets congested. We start using our beds for surge instead of assessment, surgical, medical assessment units, etc., day wards, and the whole thing just backs up. And that's where they are. Sorry, and also staff absence because of COVID.
How many staff were out?
4,800 in total, which is a significant improvement. That's over 3,000 less than last week.
Question for Paul Reid, please. Linked to both the CAM situation and the overall waiting list plan, I imagine would be trying to hire more hospital consultants. And there's hundreds of vacant posts currently. And they say that that's down to the lack of a new contract, which would attract them to those posts. Do you really hope that the government and the Department of Health will actually have that new consultant contract agreed and in place in the coming weeks so that you can try and tackle this massive waiting list backlog and hopefully the CAM situation?
Yeah, we haven't been waiting on those consultant negotiation contracts to complete. So we've been, and we still are recruiting right throughout December again. So we're still recruiting, not waiting on that. It's in all of our interests to try get those discussions to closure. And I think everybody involved in the parties would say that. And it's really, it's compelling on all parties to get that to a closure and agreement because it is right, it is part of Sláintecare, it will enhance our public capacity in our public health system. And but we haven't been waiting. It's not stopping us, but I think it would be greater clarity for us in the recruitment market if we were all to get that to closure. But I have to respect negotiations have to continue.
I know you're still recruiting, but I suppose there still is hundreds of vacant posts and the doctors say they don't want to sign up till they see the new contract. So I know it's kind of a catch-22 situation for you. So yeah,
it's an uncertainty there, but I just want to make the point, it hasn't stopped us getting people to sign up, and people are signing up on the existing contracts. But, we want to round that off and take that uncertainty out of it, not just for people signing up, but for us on the market, and to be very clear about what we're doing. But I fully respect an industrial relation process has to happen. I just really urge everybody to let's get this home.
Can I maybe just say something about the CAMS waiting list, Priscilla? So in terms of CAMS nationally, in the past year, the waiting or the referrals to CAMS went up by 30%. Now we saw also a significant increase between 2020 and 21, but in terms of the actual waiting list, so with that 30% increase in referrals, we saw only an 8% increase in the waiting list. So a huge amount of work goes on in terms of the CAMS waiting list, and about 75% of people who are referred to CAMS are seen within 12 weeks. So actually there's, it's a very quick response. If you compare the CAMS waiting list to a lot of other waiting lists, it's actually, it does very well. No, obviously we would like to have nobody waiting, but they do a lot of work on waiting lists.
That's very welcome. But a lot of GPs have told me that their referrals are being bounced back, that they're being asked, they're trying to get teenagers seen, but they're being told, does this patient still need to be seen? Are you sure? We don't think they're appropriate for the service. And then they feel like they're left with nothing to refer to. So just that's obviously an issue as well.
And that's what I mentioned earlier. A lot of our work that we've been doing in terms of improvement has actually been about developing other responses, because CAMS should not be the default option for everybody. Actually, what we need to do is develop our psychology and primary care services, and we've been doing that. And we also need pathways for children who have a disability. Often we have children who get referred to CAMS services who really need a different type of service, and we're doing that through our children's disability networks. We've had a number of clinical programs in mental health looking at things. So, for example, we have an ADHD clinical program, dual diagnosis, etc., early intervention psychosis. So all of these programs will help too, but it doesn't change overnight, and I think we have to look at the whole range of responses to young people and their mental health that don't necessarily lead them to a specialist CAMS service, but provide other levels of support at a lower level of intervention.
Paul.
Hi. Is it not time to retire the app, the COVID app, quietly now? It's kind of done its job. It seems to be completely forgotten. Somebody was in contact with me during the week. They had COVID. They wanted to give their close contacts through the app. That wasn't possible. They weren't pinged, they and their partner, like they had been when they've been previously positive earlier in the pandemic. Apart from using it to store your digital cert, it doesn't seem to have any real existence anymore.
Well, I suppose as a feature of contact tracing, as you've said, Paul, things have changed and move on in that regard in terms of other automated solutions, I suppose, for people as well. There still is, it is something we keep under review, but there still is people who use it actually, interestingly, to access some of the data around information, as well as the digital certificate. So we'll keep it under review, but at the moment, certainly from a contact tracing perspective, yes, it has a more limited value than it had in the early stages. But as I say, people do use the app for other purposes as well. So we'll keep it under review in terms of the timing, I suppose, at what point we'd make any decision like that. But as I say, the travel cert is something that people do use it quite extensively for. And the other area that we've seen people use it for is actually to access the data in terms of numbers and so on. So,
which is all on GeoHives and websites and so on.
Yeah.
But are you saying that you have considered winding it up? Or?
No, we just, I suppose, look, we keep all of these things under review as we move forward. Every time, I suppose, we make changes in the system, and we have improved the contact tracing system through other automated means where people have list your contacts portals and other ways, I suppose, that we interact with people as well. So, look, everything is up for review every time we look at the public health measures as part of a change, and that's no different. But at this stage, there's no immediate plans to take it down. And as I say, it is used extensively for the purposes of the digital certificate. And notwithstanding that the information is available elsewhere, lots of people do use it for the purpose of looking at the information, is the other bit of feedback we get.
And Paul, I was just wondering, you put in a long shift over the last 2 years, I suppose we all have, but you in particular have done it. Any plans to call it a day and move on to something else?
Today. Look, I think the people who put in long shifts, just to not be funny for a second, the people who put in long shifts are the people on the front line and the services, and anything we've been doing has been in support of them. So I know myself and the executive team will never forget that. It's what they've done has made a difference. We've been trying to add value and support them. So look, I think what I'm particularly interested in and focus on now is investing in the future of the health services and moving them on. But equally learning, many people say COVID held us back and set us back and set reform back. I'm actually of a different view. I think COVID enabled many of the aspects of Sláinte care that were written down in plans, that were in PowerPoint presentations, and we brought them to life, and we brought them into the community, and we brought them into the public. So I'm excited by what has actually happened, but now it's time to try to keep all of our lens focused, and that's why I was outlining today some of the strategic priorities for us for the future. So it certainly gives me energy, and I know that it's what the frontline services expect from us. So no was the kind of short answer now.
Just for yourself, Paul, I think there's very much a feeling of a lot of people that, COVID is kind of over now at this stage. And like that, with kind of all the restrictions lifting and things getting back to normal. I suppose, would you have any Would you share that view, or would you have any words of caution, I suppose, from the perspective of the HSE?
No, I don't think you'll hear anybody in the health system overall say it's over, and that isn't our message. At the same time, people do need to get their lives back to a level of normality, a level of what they value of what we all value in society. And if, you know, it was probably never more appropriate than now, from everything we know about where we are at this point in time, what might happen in the future, how we need to recalibrate. I certainly don't know, but you know, we may have to recalibrate in the future. But why wouldn't the public be, you know, really celebrating where we are right now and really cherishing everything that's good about how we live our lives, but being conscious it's still with us.
Again from the Examiner, just one question. I was just looking this morning at the numbers of cases in under 18s and especially 5 to 12s, and it's I know the numbers are a little bit unclear this week, but they're definitely rising week on week. Is there any concerns about that and the sort of very slow pace of the vaccination?
Yeah, maybe just on the vaccination side, look, we know that with younger people, we saw it as well with the 12 to 15-year-olds, that it takes parents time to take the information, take advice, talk to people. Now we are seeing, as I said, you know, we're over the 100,000. We still have some way to go, as I said earlier. So I suppose, look, that's something that we're working on in terms of trying to ensure we get the maximum amount of information available, have flexible options for people as well in terms of vaccinations. And you'll see some of the work the centres have done in trying to make the process as child-friendly as possible for parents. So I guess in terms of the vaccine aspect, we'll continue to work on that. You know, we don't expect the uptake to be at the level that it was with some of the other ages, just given the changing conditions as well. But it's important to remember the NIAC advice was very clear. For those people who have a risk, it's really important that they get vaccinated. They strongly recommended that. And for other children, it's recommended. So look, that clinical advice is very important, and through our hospital system and our community care system, you know, that information has been passed on to parents to try and encourage them to come forward through the various hospitals and community centres that people would be in contact with. That's the vaccine side. In terms of the increase in the numbers on young children, yes, we are seeing an increase, but it's proportionate, I suppose, to the overall numbers that are there and the numbers that are being tested. So there are extensive numbers, I suppose, being tested in terms of some of those ages that we're seeing coming through. So I think it would be premature yet to say that that's a concern. I guess our focus now is really to get the vaccination moving. And as you know, there are still measures in place for young people in relation to certain environments, such as schools. The public health have left in place through till the end of February. So I suppose it's towards that middle to end of February when that will be looked at again, Niamh.
Everybody happy? Okay, well, thank you very much.